Atelectasis is a disease of the lungs that's characterized by the collapse or closure of the alveoli, resulting in reduced or absent gas change. Usually results in hypoxia and acute respiratory failure, and it has multiple different causes, but some of the most common causes are inactivity of the alveoli caused by stasis or COPD, or compression from causes such as a pneumothorax or a hemothorax. The typical signs and symptoms that you'll see is shortness of breath, really fast breathing, coughing, and fever, chest pain, hypoxia, and irritability or restlessness, and that's due to the anxiety from not being able to get enough oxygen. To prevent this, usually nursing management includes turning, coughing, and deep breathing, early ambulation after surgery or while recovering in the hospital, incentive spirometry, oxygen monitoring, and frequent turning and secretion management. Nursing management also includes encouraging ambulation and deep breathing, taking care of oral care, which is super important for hygiene and can affect the respiratory system, and teaching. Pneumonia is an infection of the lung tissues and the fluid accumulation within the lungs. This disease process makes it very hard to breathe and impairs gas exchange. It's typically caused by a bacterial infection, but may also be caused by viruses or fungi. There are 4 main types of pneumonia: healthcare-associated, hospital-acquired, community-acquired, and ventilator-acquired. All types can be diagnosed with a sputum culture and blood work. Risk factors for pneumonia include underlying conditions already impacting the lungs, smokers, admissions to the hospital, advanced age, and immunosuppression. Signs and symptoms that may be seen include fever, cough, chills, general weakness and tiredness, chest pain, dyspnea, tachypnea, abnormal breath sounds such as crackles and rhonchi, and purulent sputum. The treatment of pneumonia depends on the cause of the infection. Antibiotic therapy, for example, would be given for a bacterial pneumonia infection. Other treatment and nursing management also includes fluids, supplemental oxygen, bed rest, antipyretics to get the fever down, bronchodilators, and coughing, turning, and deep breathing. Acute respiratory failure is from a culmination of different respiratory mechanisms failing. This results in inadequate ventilation and oxygenation, leading to hypoxia, hypercapnia, and respiratory acidosis. Typically, this results from either ventilatory failure or oxygenation failure within the lungs. This can also be caused by a number of diseases or risk factors. The signs and symptoms of acute respiratory failure are kind of divided in between early signs and late signs. Early signs include difficulty breathing, fast breathing, accessory muscle use, diaphoresis or sweating, changes in level of consciousness, restlessness and agitation from the anxiety of not being able to breathe right, headache, and fatigue. Later signs include confusion, lethargy, respiratory arrest, dyspnea, tachycardia, dysrhythmias, bradycardia, and central cyanosis. Treatment and nursing management includes primary management, that is to identify and treat the underlying cause of acute respiratory failure. Respiratory failure will happen due to another disease process. So to treat that underlying disease process first is really important. Supplemental oxygen to increase the amount of oxygenation in the body. If the acute respiratory failure is severe, then intubation and mechanical ventilation may be necessary. Reduce the patient's anxiety, prevent complications caused by decreasing lung function, and nutritional support if they are intubated and mechanically ventilated.
Acute respiratory distress syndrome, ARDS, can be thought of as a spectrum of diseases. It is a clinical syndrome characterized by a severe inflammatory process causing diffuse alveolar damage that results in sudden and progressive pulmonary edema. increasing bilateral infiltrates on chest x-ray, hypoxemia unresponsive to oxygen supplementation, and patients often demonstrate reduced lung compliance. There are a wide range of factors that are associated with its development. This includes direct injury such as smoke inhalation, aspiration, localized infection, drug overdose, fat or air embolism, and metabolic disorders such as pancreatitis. Indirect injuries include sepsis, shock, or trauma. Patients who do survive the initial cause of ARDS may die later, commonly from healthcare-associated pneumonia or sepsis. Its pathology is the inflammatory triggers that initiate the release of mediators, causing injury to the alveolar capillary membrane that also damage other structures of the lung and decrease lung compliance. This results in a severe VQ mismatch. For the clinical manifestation, it generally resembles initially severe pulmonary edema. This acute phase is marked by a rapid onset of severe dyspnea that usually occurs less than 72 hours after the precipitating event. Arterial hypoxemia that does not respond to supplemental oxygen is characteristic. ARDS is classified according to the severity of hypoxemia that the patient experiences. Diagnostically, the chest ray, we're going to see it's going to look similar to cardiogenic pulmonary edema, and there are visible bilateral infiltrates that quickly worsen. On physical examination, we will see intercostal retractions and crackles that may be present as the fluid begins to leak into the alveolar interstitial space. Common tests that are performed are the BNP levels, because it's helpful to distinguish ARDS from cardiogenic pulmonary edema. The primary focus in the management of ARDS includes identification and treatment of the underlying condition, and then aggressive supportive care must be provided to compensate for the severe respiratory dysfunction. This usually always includes ET intubation and mechanical ventilation. In addition, circulatory support, adequate fluid volume, and nutritional support are important. Supplemental oxygen is used as the patient begins the initial spiral of hypoxemia. The concentration of oxygen in ventilator settings and modes are determined by the patient's status. This is then monitored by arterial blood gas analysis, pulse oximetry, and bedside pulmonary functional tests. Providing ventilatory PEEP support is a critical part of the treatment. This helps to improve oxygenation. There's no specific pharmacological treatment of ARDS except supportive care. Neuromuscular blocking agents, sedatives, and analgesics may be used to improve patient ventilator synchronization and help to decrease severe hypoxemia. Nutrition is vital to the treatment. They should require about 35 to 45 kcal per day to meet caloric requirements, and enteral feeding is the first consideration. However, peritoneal nutrition may be required. For nursing management, it requires close monitoring in the ICU, including oxygen administration, nebulizer therapy, CPT, ET intubation or tracheostomy, mechanical ventilation, suctioning, and bronchoscopy. Frequent assessment of the patient's status is necessary to evaluate the effectiveness of the treatment. Positioning is also very important. We should turn the patient frequently to improve ventilation and perfusion in the lungs and enhance secretion drainage. However, we must closely monitor the patient for deterioration and oxygenation with changes in position. Sometimes oxygenation in patients with ARDS is improved in the prone position. The patient with ARDS is going to be extremely anxious and agitated because of the increasing hypoxemia and dyspnea. It is important to reduce the patient's anxiety because anxiety increases oxygen expenditure by preventing rest. Rest is essential to limit oxygen consumption and reduce oxygen needs. Pulmonary embolism refers to the obstruction of the pulmonary artery or one of its branches by a thrombus that originates somewhere in the venous system or on the right side of the heart, which will cause absent or impaired gas exchange in the area and increased pulmonary vascular resistance. Most commonly, it is due to a dislodged or fragmented DVT. Symptoms of PE depend on the size of the thrombus in the area of the pulmonary artery included. Dyspnea is the most frequent symptom. Chest pain is common and is usually sudden and pleuritic in origin. However, it may be substernal and may mimic angina. Other symptoms include anxiety, fear, tachycardia, apprehension, cough, diaphoresis, hemoptysis, syncope, and most frequently tachypnea. The initial diagnostic workup may include chest x-ray, ECG, pulse ox, and ABGs. The medical management is the immediate cardiopulmonary system stabilization. If they're hemodynamically unstable, we're going to treat this with thrombolytic therapies, such as with TPA. The risk of bleeding is significant. So to manage the thrombolytic therapy, the nurse is responsible for managing the patient's response to the therapy. So we're going to monitor their vital signs frequently and avoid procedures that are invasive and monitor the INR and PTT. The position of semi-Fowler is the most comfortable for breathing. However, the nurse needs to continually turn the patient and reposition them to improve their VQ. The nurse may also administer opioid analgesic agents for the severe pain. The patient must be on continuous oxygen therapy, which the nurse will assess frequently for signs of hypoxemia and monitor the pulse ox. Deep breathing and incentive spirometry are indicated for all patients to relieve atelectasis and improve ventilation. For the patient may have great anxiety, so we should encourage them to talk about any fears or concerns related to the frightening episode, answer any questions concisely and accurately, and then we must monitor for complications. We must be alert for cardiogenic shock or right ventricular failure subsequent to the effect of the PE on the cardiovascular system. Pulmonary hypertension is characterized by elevated pulmonary arterial pressure greater than 25 millimeters of mercury at rest and greater than 30 millimeters of mercury with exercise and secondary right heart ventricular failure. For clinical manifestations, dyspnea is the main symptom. Then it occurs first with exertion and eventually at rest. Substernal chest pain is also common. Other signs and symptoms include weakness, fatigue, syncope, occasional hemoptysis, and signs of right-sided heart failure, such as peripheral edema, ascites, descended neck veins, liver engorgement, crackles, and heart murmur. Anorexia and abdomen pain in the right upper quadrant may also occur. Initial diagnostic evaluation includes a history, physical examination, chest x-ray, pulmonary function test, ECG, and echocardiogram. The primary goal of treatment is to manage the underlying condition related to the PH if the cause is known. All patients with PH should be considered for the following therapies: diuretics, oxygen, anticoagulation, digoxin, and exercise training. The major nursing goal is to identify patients at high risk for PH, such as those with COPD, PE, congenital heart disease, and mitral valve diseases, so that early treatment can begin. The nurse must be alert for signs and symptoms, administer oxygen therapy appropriately, and instruct the patient and family about the use of home oxygen therapies. It is important to provide contact details for support services for patients and families. Cor pulmonae is a condition that results from PH, which causes the right side of the heart to enlarge because of the increased work required to pump blood against high resistance through the pulmonary vascular system. This causes right-sided heart failure. It is most often caused by severe COPD. Management includes supplemental oxygen, diuretics, and anticoagulation therapy to reduce heart failure symptoms. Nursing care involves patient education on at-home management and support group access. Mechanical ventilators are initiated to facilitate oxygen to the tissues. They can help support the patient until the initial cause of their respiratory failure can be treated. Together, a healthcare team will collaborate, determine the type of mechanical ventilation that the patient needs, and they can decide on the settings such as volume cycled, the pressure cycled, and the high frequency that is cycled. Indications for mechanical ventilation include apnea, bradypnea, respiratory failure, if the patient has a compromised airway, if the patient has respiratory distress with confusion, as well as increased work of breathing, if other interventions have failed, and they can have confusion and they need to protect their airway, shock, or if we need to control the patient's respirations during surgery or different procedures. There's a lot of potential complications with the use of a ventilator. This could include problems with the actual ventilator itself, depending on the volume and rate changing. This could lead to ARDS. There can also be alterations in cardiac function due to the decrease in venous return to the heart from the pressure added in the lungs. There can be barotrauma. There can be a pneumothorax. There may be pulmonary infections. For the nursing management, our goal is to improve oxygenation and ventilation, so we need to focus on positioning. We want the least affected area of the lung in the most dependent position. This could be semi-recumbent. We want to elevate the head of the bed and reposition every 2 hours, and then as we can, early mobilization. We want to prevent desaturations, so we want to hyperoxygenate the patient before suctioning, and we want to minimize activity so that we can rest between procedures. So we definitely want to cluster care. We also want to focus on secretion clearance. This helps with hydration, humidification, nebulizer treatment, mucolytics, turn, cough, deep breathe, chest PT, and then we can suction as needed. Again, we want to prevent any complications, so we want to initiate any care bundles, such as for pneumonia. We want to prevent any hospital or ventilator-acquired pneumonia. Oral hygiene is very important. We want to do the chlorhexidine swabs and brush the teeth. We want to prevent barotrauma, oxygen toxicity, ICU delirium, and any anxiety the patient may have. Pulmonary edema is defined as abnormal accumulation of fluid in the lung tissue, the alveolar space, or both. Non-cardiogenic pulmonary edema occurs due to damage of the pulmonary capillary lining and can develop slowly. It can be due to direct injury of the lung, including chest trauma, aspiration, and smoke injury, or it can be a hematogenous injury to the lung, which may be sepsis, pancreatitis, kidney injury, multiple transfusions, cardiopulmonary bypass, or injury that elevates hydrostatic pressures. The clinical manifestation includes decreased cerebral oxygenation, which causes the patient to become increasingly restless and anxious. There may be a sudden onset of breathlessness and a sense of suffocation. The patient may also be tachypneic with low oxygen saturation levels, and the skin and mucous membrane may be cyanotic and pale. The hands may be cool and clammy. Tachycardia and JVD may be present. Incessant coughing may occur, producing increasing quantities of foamy sputum. If it is recognized early, pulmonary edema may be alleviated by increasing dosages of diuretics and by implementing other interventions to decrease preload. For instance, we could place the patient in an upright position with the feet and legs dependent, which will reduce the left ventricular workload. The patient's airways and breathing are assessed to determine the severity of respiratory distress along with vital signs. The patient should be placed on pulse oximetry, a cardiac monitor, and IV access should be established or confirmed to administer medications. Lab tests that are obtained include arterial blood gases, electrolytes, BUN, and creatinine, as well as CBCs, BNP, and troponin. A chest X-ray or ultrasound of the lungs may be obtained to confirm the extent of the pulmonary edema. Oxygen is given in concentrations adequate to relieve hypoxemia and dyspnea. A non-rebreathing mask may be used initially. If respiratory failure is severe or persistent, non-invasive positive pressure ventilation is a preferred mode of assisted ventilation, although some may require ET intubation and mechanical vent. We want to go ahead and reassure the patient and give the patient and their family simple, concise information in a reassuring voice about what is being done to treat the condition and the expected results. The medical treatment includes vasodilators such as IV nitroglycerin, which may enhance the symptom relief in pulmonary edema. We also want to use diuretics such as Lasix or another loop diuretic. These can be given by IV push or as continuous infusion to produce a rapid diuretic effect. With both these medications, we want to make sure to monitor the blood pressure and monitor the urine output. It is possible for the patient to develop hypokalemia due to the diuresis, so we should also keep an eye on their electrolytes.
This slide is about chest trauma, which can be blunt and penetrating chest trauma. So basically it refers to any injury involving the chest wall, lungs, heart, or vessels around it, like the aortic or pulmonary, just the big vessels. Blunt trauma usually occurs from like any car accidents, car accident, falls, or sports injury causing internal damage through compression or shearing forces. Penetrating trauma occurs when an object like a knife or a bullet enters the chest, creating an open pathway for air or blood to enter the thoracic cavity. Some signs and symptoms include like some chest pain, some difficulty bleeding, you might have some bruising. One common one is asymmetrical chest expansion. So basically one side of the chest is expanding while the other isn't, and decreased breath sounds. When this happens, basically as a nurse, if it's unstable, if there's like complications, you're going to want to maintain the airway. You want to give them high flow oxygen, stabilize the impaired object, but do not remove it. You do not want to remove the penetrating object. You want to control the external bleeding, like cleaning it up, but like I said, do not remove that. A pneumothorax means air or fluid got into the space around the lung, making the lung collapse. The person will suddenly feel like a sharp chest pain, shortness of breath. You may not hear breath sounds on the injured side. In bad cases, the trachea can shift over to the opposite side, and the blood pressure can drop. Basically, as a nurse, you're going to give oxygen, watching the breathing closely, and getting ready for needle decompression or a chest tube. So chest drainage, you're going to want to use this for a pneumothorax. It's going to help remove that air and fluid from the lung so it can expand. Our job as a nurse is to keep the drainage box below the chest. It helps with gravity. And you're going to want to monitor that chamber and check the water seal for normal movement and watch for bubbling, which can very well mean an air leak, and you want to tell the doctor so they can fix that. We also check the dressing around it to make sure the tube isn't kinked and monitor how much drainage is coming out. What you're never going to want to do is never clamp the tube unless the doctor specifically says so. Cardiac tamponade happens when fluid builds up around the heart and squeezes it. So it's not inside the heart, it's surrounding the heart. The heart can't pump well, so the blood pressure drops. The 3 big signs are going to be muffled heart sounds, low blood pressure, and a big puffy rectane, which is jugular vein distension. As the nurse, we give oxygen, make sure there's IV access, watch the vitals, and get ready for the doctor to drain the fluid with the procedure called a pericardiocentesis. Metabolic acidosis means the body has too much acid. This happens with things like kidney failure, diarrhea, or diabetic ketoacidosis, DKA. The patient may breathe fast and deep, may feel confused, and their potassium might be high. As a nurse, we're going to want to treat that cause, like giving them insulin or watch potassium, and we're going to monitor the heart. However, metabolic alkalosis, meaning the pH is high, means the body has too much base or has lost too much acid through metabolic ways. This happens with a lot of vomiting or NG suction. The patient may breathe slower, feel tingling, or have muscle cramps. We treat what's causing it, like stopping the suction and replacing the electrolytes, especially potassium and chloride. Respiratory acidosis happens when someone isn't breathing well enough and CO2 builds up. This happens with COPD, opioids, or even pneumonia. The patient might feel confused, sleepy, short of breath. What you want to do as a nurse is improve the breathing, oxygen, give them breathing treatments like BiPAP or CPAP. Respiratory alkalosis happens when someone is breathing too fast, hyperventilation, and blowing off too much CO2. This can be caused by anxiety, a fever, even sepsis. They may feel lightheaded, have numbness and tingling. We're gonna, as a nurse, we're gonna encourage them to breathe slower, reduce their anxiety, or whatever is causing them to breathe too fast.